Good morning, everyone. So I'll be speaking on manual preparation of DSEK lenticule and the surgical technique of manual DSEK. So first of all, I would like to draw your attention to this recently published article in IJO, where Pamaji et al. Highlighted the trends in the indication of keratoplasty in last 2 decades in North and Central India. And if we see this table, post-cataract surgery edema is one of the most important reasons for which keratoplasty was done in last 2 decades here. And as Dr. Prafulla already mentioned that endothelial keratoplasty is the procedure of choice for these cases. But still, if we are doing full thickness keratoplasty for them, just because of the reason that we don't have access to automated keratome or our patient cannot afford pre-cut lenticule, then it's not good, because manual preparation of donor lenticule is really doable and it gives equally good results. So if you are working in resource limited setting, like I'm working in medical college, and all the medical colleges and government institutions, we have eye banks with us, so we have access to cornea, but neither we have automated keratome nor we have a specular microscope. So the question is, without knowing endothelial cell counts, can we use any tissue for DSEK? The answer is yes, we can. I'm going to share with you how we have started our DSEK journey in the medical college just 3 years ago. So after reading few articles of Dr. Samar Basak sir, we made a protocol in the department. And whenever the retrieved cornea fulfills these criteria which are listed over here, then only we use that tissue for DSEK. So we kept the maximum age of donor 65, maximum retrieval time within 6 hours of death. We always use phakic eyes. Definitely corneasol preserved tissue we use, and at least good grade corneal tissue on slit lamp examination. So now let's come to this, how many instruments and what we need for the preparation of DSEK lenticule manually. So we need artificial chamber. I use titanium one. We need 2 lamellar dissector, straight and curved one, Sinski and disposable refine for marking, 350 microns guarded knife for initial incision, crescent knife for initial dissection, marker 5 ml syringe. We need graft holder, Macpherson, Teflon block, and good quality cornea. Now let's come to the manual preparation of DSEK lenticule. So after mounting your cornea on the donor cornea on the artificial chamber, first we mark the center with Sinski and disposable refine. Then at limbus, we will give 3 mm incision with 350 microns guarded knife. And initial dissection, we always start with crescent knife. And once we get the plane deep enough, then we take straight lamellar dissector first and go up to the center. And then I always dissect on one side first, complete it, and then I'll come back to the center and then on the other side. And we will have to dissect all the way away from the this refine mark, because at the time of final cut, we don't want any additions, as Dr. Karan had shown you in one case. Now we take the curved lamellar dissector and we go to the opposite limbus straight away. Then we will repeat the procedure, complete on one side and then on the other side. And it hardly takes 7 to 8 minutes in preparing this lenticule. Now let's come to the surgical technique. So if you are a beginner, you have not done DSEK surgery. So as we all know, there are so many causes of endothelial dysfunction. So always start with a straightforward case of pseudophakic bullous keratopathy. And straightforward means your IOL should be in posterior chamber. There should be deep AC, because we will do lots of manipulation in the AC. Minimal or, no peripheral anterior synechiae is the preferred one, and no central corneal scarring, stromal scarring for the good results, and to increase your confidence. Now, keep minimum 3 months window period between the cataract surgery and the planned DSEK. You can keep it more, but at least 3 months. And definitely there should be some potential for visual recovery. So now preoperative workup is same as we do in all cases of cornea, but here AIOC is very important for us, because we do AIOC preoperatively to measure the thickness of cornea. Like in this case, you can see 957 is the preoperative corneal thickness, but if you can appreciate, there's no stromal scarring. So these are the good cases to start with. And then we do AIOC on day 1 to see the attachment of the lenticule. Here you can see the attachment, perfect attachment. You can see the orientation by seeing this acute angle. And more importantly, because we don't have automated keratome, so we cannot measure the thickness of lenticule intraoperatively. So we will do it on day 1. And we will keep it as a baseline. Then at different time intervals during follow-up, we keep on doing ASOCT and we can compare our results. And you can see after 1 year follow-up, the overall corneal thickness is only 618 microns, out of which lenticular thickness is 111 micron. And preoperatively, you just see here, it was 957. So it is really encouraging. Now let's come to the surgical technique. So we'll start with descemetorrhexis. So after debriding the loose epithelium, we will mark the center. Actually, this is reference marking, which will guide us during descemetorrhexis as well as at the time of DSEK lenticule centration. In this patient, I was sitting temporarily, so I made a side port at 6 o'clock. And then I stained the descemetes with trypan blue. I usually prefer to do descemetorrhexis under viscoelastic. So because chamber doesn't collapse so much. Then with reverse Hinsky, we will keep on scoring from all around in a circle. And if you feel like that chamber is collapsing, you can refill the chamber with viscoelastic again. And once you are sure that you have scored the descemetes from all around, then you fold it and try to bring it towards the side port. And at the end, we should always examine the descemetes under microscope to confirm that we have taken it out completely or the tags are left behind. That is very, and then you wash the chamber thoroughly to remove all the viscoelastic. I use push-in technique with 2060 needle. Here I'm using 2 limbs forceps, one for holding the cap and one for holding the lenticule. I put 1 drop of cohesive viscoelastic in front of the clear corneal incision, and I kept the lenticule endothelial surface down in front of the incision. And then with 2060 bevel up needle, I take it inside the AC. And if you can notice, it is not opened completely. So I'm using BSS. I go over the stromal surface and just inject little fluid, and it is open now. If like this, in this case, it is very well centered. So I just inject more air. We need high pressure in the eye at least for 1 hour. And end point is just see the double ring sign. This is another case, but this was a case of aphakic bullous keratopathy. Again, I'm using the 2 limbs forceps. And just place it near the clear corneal incision. And with 2060 bevel up needle, gently you just take it inside. And that's it. And either from the main port or from the side port, just put a small air bubble if it is not centered. So after stroking, it will come in the center. Then inject more air. And end point is again the double ring sign and high IOP. So double ring sign actually is the confirmation of the correct orientation of your lenticule intraoperatively. Post-op and follow-up regime is same as we do in all cases of full thickness keratoplasty, but less aggressive with obvious reasons. So now let's come to the results. So first we will show you the immediate post-op results. This was the case whose video I have shown you. So in this slide we have shown the day 2 post-op and 1 month post-op after manual DSEK. And these patients have completed 1 year follow-up with us after manual DSEK. They have completed 2 years of follow-up. They have completed more than 2.5, in fact, near about 3 years follow-up with us. And we have done manual DSEK for long-standing bullous keratopathy cases also, where the visual recovery is not that great because of this stromal scarring. But symptomatically, these patients also, they do very well. And they are very happy patients because all photophobia, watering, pain, all is gone. Complications are part and parcel of any surgery, so we encountered a few like graft detachment in this case, but this graft, you can see the central graft detachment and it was reattached with rebubbling. Pupillary block glaucoma is common when we are a beginner because in apprehension of graft detachment, we overfill the chamber. So the tip is at the end of surgery, just put 1 drop of atropine. And 1 hour is more than enough for a graft to get attached. So bring your patient back in OR and do air fluid exchange. And just leave a slightly smaller air bubble than your lenticule. Then you won't encounter with this complication. Post-DSEK infection is not that common. But when the patient is suffering from other systemic illnesses like uncontrolled diabetes, this patient was on dialysis, not very compliant with follow-ups and medication. So she developed. And in this case, I made a scleral tunnel for graft insertion. And I found that that was not self-sealing. So make sure your tunnels should be self-sealing whenever you make scleral tunnel. Our initial work of manual DSEK we have published in Indian Journal of Clinical and Experimental Ophthalmology. So if you want to start your manual DSEK journey, it could be of help. So please go through it. And in the last, I would like to conclude by saying it's a very safe, feasible, and low-cost surgical procedure with good visual outcome. Thank you. Thank you for patient listening.
Thank you, Dr. Shefali. Since these were the two talks on DSEK, so any questions from the audience about manual DSEK? Any points from the panelist? Okay, Dr. Shefali, one question. You use viscoelastic for decimal scoring. So could you specify which viscoelastic you would prefer and which you should avoid?
Actually, cohesive is better. So we can take it out.
It's always cohesive, like
yes.
Hilon, because that comes as a bolus.
Easily.
If you use something like HPMC, then that will stick to the endothelium or the stroma, posterior stroma, and there is a risk of graft detachment of fluid in the posterior period. So that is one part. And how do you assess? Because most of the time for beginners, when they start the dissection plane, how do you decide what exactly is your dissection plane?
Actually, I put a small air bubble in the and when you start dissecting, if you are in the deeper plane, it goes very easily. When you are in the deeper plane, because the arrangement of corneal stroma fibers are not that cross-linked or very tough.
So endpoint is start with little bit resistance. Then once you feel that okay, my dissection is going easy, don't go further deeper. I think
yes,
that is what is for manual dissection.
Once you get a plane, then you'll have to be in that plane only. Otherwise, it will not be very smooth, and it will not. 350 for initially as a beginner they can start with, and when you become confident, you can use 450 microns guarded knife. 450 is okay. Preoperative OCT? Yes.
So that we can decide at what depth we should go, how thick is the cornea and all those things.
Depending on the pre-op OCT, we decide the thickness of lenticule.
Guarded knife.
Guarded knife. No, not at all. Because you will have to debride the epithelium also. Then you don't know what would be the rest of the corneal thickness intraoperatively. Standard in the beginning, just 3 years ago, I started what I saw at day 1 post-op. It was 250 microns, my lenticular thickness, which came to 100 microns within a year. But now I can go ahead with 150 microns.
That is what we discussed. You have to practice. If you want to do EK, practice in wet lab. Thank you, Dr. Shefali.
Thank you.
Thank you.
Yes, please. Meanwhile, Dr. Bhupesh, you please get ready your PPT.
Yes, you can. See, you can give results in PK. Okay, when you are confident, you can use that tissue for PK. That was the thing which came into my mind. If I can give result with this tissue in PK, I can also use this tissue for DSEK. Let me try. And that's why we started very slow. In last 3 years, we have done only 40 cases. So, and you see, we waited for the results. Initially, we were very slow. In 1 month, I did only 1 case. And then I was confident, yes, my cornea is good. And if you use slit lamp examination, you use phakic eyes where no intervention was done in the life, then definitely you can expect the good endothelial cell count, and age is again a thing. So these are the few things, and definitely corneasol preserved tissue.
So there are, as the Dr. Shefali highlighted, based on history, like patient factor, and also clinically you can see the compactness of stroma and age of the donor. If the donor is below 40, most likely the endothelial count will be good, right? And the stroma is contact, again the endothelial count will be good. And third is you can also check for death preservation and death enucleation time. If the tissue is enucleated within 6 hours, then most likely the tissue will be good quality. Anything above that, little bit worried about the, and also type of cause of death. Sudden cardiac arrest, tissue will be good, but hanging, road traffic accident, the most likely some sort of trauma to the cornea may be there.
Like I'm working in the medical college, so hospital corneal retrieval is not that good in our college. So usually we get voluntary donation. So most of the time the age of the donor is above 70. So we don't use it. We always restrict to 60, 65 plus only cornea. That's the maximum age limit for using that tissue for DSEK preparation.